and it's not going straight down. I'll come to talk about this later. Okay, that's the stomach. What about the fourth chamber? Well, this fourth chamber, many of the abnormalities are very obvious. Is this a hypoplastic left heart or a hypoplastic right heart? Descending aorta, left atrium, left ventricle, hypoplastic right heart. Again, apply your rules. This baby here, when you look at this, the descending aorta, left ventricle, right ventricle. This is a baby with a hypoplastic left heart. I don't think anybody in this room will miss these diagnoses when they go to work tomorrow morning. They are very straightforward and easy diagnoses with a detection rate of 90% or more. Very important diagnosis to make if a mother wants to know about it. In fact, we make these diagnoses at 12 weeks, 13 weeks gestation, not at 20 weeks of gestation. It's a very straightforward diagnosis. But sometimes it's more challenging, where the left ventricle is small, or the right ventricle is small, or the left ventricle is big, or the right ventricle is big. So when you look at this case here, descending aorta, left atrium, left ventricle. This left ventricle is smaller when compared to the right ventricle. So I'm worried about coarctation, I'm worried about mitral atresia with VSD, and I'm worried about interrupted aortic arch. In this baby, right ventricle is enlarged, big, and that's typical of critical aortic stenosis. There are not many conditions that cause enlargement of the left ventricle. The other possible cause would be a left ventricular aneurysm, rare. What about the right side? This is the right ventricle that's easy to miss. So this is the descending aorta, left atrium, left ventricle, right ventricle. But it's very easy to miss this right ventricle. It's very easy to miss that this baby has got a serious problem. This is a baby with pulmonary atresia with intact ventricular septum. This is a baby who's got a hypoplastic right heart. And the case that we saw today to you was critical pulmonary stenosis. And the other differential is pulmonary atresia with intact ventricular septum or tricuspid atresia with VSD. But it can be so easy to miss. And that's why you need to compare the sizes of the left and right ventricle on the 2D with color. This is the opposite. This is the right ventricle that's big. And this is the baby who's got a right ventricular aneurysm. Descending aorta, left atrium, left ventricle, right ventricle. You can see the disorders inside. Four chambers can also pick up VSDs. They're generally very easy to pick up with color, harder to pick up with 2D. If you see VSDs with 2D, most of these tend to be larger. One of the muscular VSDs are very small, and many of these close. This looks like an ASD. ASD and VSD, here and here. You say to me, Simon, are you sure it's an ASD? It could be a dilated coronary sinus, because dilatation of the coronary sinus can look so like an ASD. And if you think it is a coronary sinus and you're not sure, then look for the direction of flow. Because if it's a coronary sinus, the flow is from left to right. This is a baby with a dilated coronary sinus. And if the flow is from right to left, well, then it's an ASD, which is this baby here. So remember, if you're stuck, look at the direction of flow to find out whether it's an ASD or not. You go to work tomorrow morning. You say the descending aorta, left atrium. You say, wow, that's so big. What is that? And this baby here, 24 weeks, say, wow, it's so big. What is that? And that is a very, very dilated coronary sinus. If you see a huge coronary sinus, it usually means there's a persistent left and no right SVC. So the whole head and neck being strained is coming down on the left-hand side, going across behind the heart and then coming to the right side. What about AV valve regurgitation? Descending aorta, left atrium, left ventricle. Mitral valve regurgitation. I know is abnormal. Mitral is rare. And I've already spoken. Descending aorta, tricuspid valve regurgitation. What about this baby? What strikes you? Can anybody in the room tell me what is the problem? first thing is you need to be aware that half of the heart is in the left hemithorax and half of the heart is in the right hemithorax. This is abnormal. Normally, 2/3 of the heart should be on the left and 1/3 of the heart should be on the right. So this is a baby with mesocardia, where the heart is situated centrally within the chest. And anytime I see mesocardia, I think first, number one, TGA, transposition of the great artery. This baby does not have transposition. It has a hypoplastic right cardiac ventricle with pericardial effusion. This baby, the axis of the heart is at 3 o'clock. This is a baby with a left cardiac axis deviation. Again, we have a patient to you this morning with a common arterial trunk at 12 weeks. And we recognized it straight away as we saw the heart, the apex was at 3 o'clock with a right aortic arch. A 13-week scan with left axis deviation of right aortic arch, but most of them will be tetralogy of fallow pulmonary atresia. So this is a baby with left cardiac axis deviation with the aorta sitting directly in front of the spine. So remember to check the axis of the baby's heart. Also, remember to look at the 4 chambers, the size of the heart. The cardiothoracic ratio should be 50% or less. And if it's more than that, you consider why is the heart enlarged. Remember, when you see cardiac rhabdomyoma and you say, Simon, oh, that's interesting, there's only one cardiac rhabdomyoma. Every time somebody knocks on my door and says, Simon, I see one cardiac rhabdomyoma, I say, no, let me look. Because every time I find more. It is very rare, in my opinion, with current day technology to see solitary rhabdomyomas. This baby has multiple rhabdomyomas. And you have to look with high frequency to see them. And it's important because if you see multiple additional cardiac rhabdomyomas, you know that the chances of tuberous sclerosis is much higher. So never accept one. Always doubt it and go looking for more. This baby's got a pericardial effusion. Sometimes it looks like muscle. You say, I don't think that's a pericardial effusion. I think that's cardiac muscle. If you want to know if it's muscle or whether it's true fluid, then you look at slow flow and turn down your balance, and you'll see true flow motion in the pericardial space. Also to you this morning, so pericardial. So remember, slow flow is a very powerful tool to bidirectional flow in the pericardial sac. And distinguish between them. If I see fluid, the first thing I do is I do a little cerebral artery systolic velocity, because it's one of the first ways the baby presents with parvovirus fetal anemia. And then, of course, Down syndrome. And if I look at both of these babies, different babies, in 2026 and 2024, both of these, there's no question, both of these have got huge pericardial effusions. And these are typically seen in babies with parvovirus. Now, it's not the anemia. I don't believe it's the anemia that causes these huge pericardial effusions. I think this is a viral myocarditis in parvovirus that produces a severe effusion. Also, in the 4th chamber, you may see a dilated right atrium as part of aneuploidy, or you may see a dilated right atrium as part of Epstein's anomaly. And we also saw it to you this morning, the case of Epstein's anomaly. And you look